So we're going to change things up just a little bit. You know, I kind of got the feel on Wednesday as we were going through technique that we're kind of over technique for now. So we're going to take a diversion. We're going to look at sharpness, recorded detail, and geometric factors, and then we'll get back to technique when we get into patient factors towards the end of the chapter. So it's not going away, but we're going to take a diversion since we kind of hammered technique in the last section of the last test. We'll kind of take a break from it. And I got to apologize if I have a sneezing fit. The green monster that is the pine tree pollen is just wearing me out. My eyes are itching, my throat's scratchy. On the way home, or way back from lunch yesterday, I stopped and washed my truck, and by the time I got out at about 4 o'clock, you couldn't tell. So it's that bad right now. Hopefully this rain that we're getting will, help to get rid of some of that. So where we're going to pick up today, we'll run back through what we did on Wednesday, just kind of review that. But where we're going to pick up today is going to be with geometric factors. So we're going to talk about sharpness, recorded detail, and digital imaging individually with the effects of the geometric factors. But we're going to start with magnification today and possibly get into distortion, shape distortion. So kill the lights a little bit and we'll talk about all this. It's going to be a little bit darker in here today because of the overcast, so I'll fall asleep. All right, so skip the overview. So radiographic quality, again, is accurate representation of the anatomy, and that's in not just the size and shape, but also in the appearance of the anatomy. So overall contrast density play into that as well. So what we'll want is high spatial resolution, high contrast resolution, absence of noise in as much as we can, and absence of artifacts that we can remove from the patient. Obviously external artifacts that are movable, some are not, and internal artifacts you can't really do anything about. So contrast and density, we talked about those. We talked about subject contrast and radiographic contrast, how we have to have subject contrast to give us radiographic contrast. And contrast just means difference. So different tissue types give us different differential absorption, which gives us a different appearance in those tissue types on our image receptor, and that is radiographic contrast. And density in the patient is the compactness, the hardness, or the atomic number of, or really the Zeph number, the Z effective or effective atomic number of the tissue types. And that controls, again, our differential absorption in those tissue types. And the density, radiographic density, is inversely proportional to patient density. As patient density goes up, radiographic density for that tissue type goes down. So density, radiographic density, is the darkening of the image, be it the entire image or the individual tissue type that we're looking at. So we got spatial resolution. Spatial resolution, remember, there's a lot of different ways to identify spatial resolution on your test question. Spatial resolution, sharpness, recorded detail, detail all by itself, resolution all by itself, all mean the same thing, and that is spatial resolution, which is how sharp is the shadow. Contrast resolution is really your visibility or recorded detail and whether or not you can see that detail, right? So visibility or recorded detail. Contrast resolution is always going to have the contrast before the resolution whenever we're talking about contrast resolution. But contrast all by itself just means the same thing. So it's visibility or recorded detail. We talked about the different types of noise. The most common is fog. You can't get rid of all the fog. We just want to minimize it, and we have certain steps for minimizing it. And there's two different ways essentially to minimize it, and that is prevent it from being created or clean it up after it is created. So we talked about prevention, some of the methods of prevention in the last section, and we went into that on Wednesday. And that is with KVP, collimation, and then we're going to talk about cleaning up the scatter in the next section. The quantum model is always about one thing, that's not enough signal, right? And signal being the X-ray beam, and the amount of signal in the X-ray beam is controlled by mass, so it's always not enough mass. How we get to that insufficient amount of mass, we got a lot of different ways. So we talked about electronic interference as well. So spend some time on quantum model, still some time on quantum model, even more time on quantum model. And then we talked about image receptor speed. So we talked about image receptor speed in its context in two things. One is its potential responsibility in causing quantum model. The higher the speed, the less mass we need. The less mass we need, the more likely, theoretically, that we're going to create quantum model. We also talked about the effectiveness of our image receptors now that quantum model is more difficult to demonstrate, even though theoretically it should be easier to demonstrate because our image receptors are so fast that, and we can use a higher KVP, both of which could potentially cause us to have lower mass and introduce quantum model. We just don't see it quite as much as what we used to. So we took a look at the H&D curve, and the portions of the H&D curve that we were interested in were really the straight line portion. We had to know about the shoulder, which is extreme dark portions of the H&D curve. The toe portion, the shoulder and toe portions are really outside of our diagnostic range. So they're good to identify, but in as much as how they relate to image quality, that would be in your extremes of exposure. So the portion that we really were interested in seeing was the straight line portion, and in the context of how we identify things with the H&D curve. Now, remember, they represent really your lookup tables. So that a very vertical H&D curve would be associated with a lookup table that we wanted to demonstrate very high contrast. It goes from low density to high density very quickly, so it's high contrast. Black and white, very dark, very light densities, so very black and white. More horizontal H&D curve, and we'll get back into that deeper later on, but a more horizontal H&D curve will give us something more along the lines of a chest x-ray where we wanted to have a more gray image, right? So we looked at all that. Again, speed, optical density, we talked about that again, and that really leads us up to where we're gonna start today. So any questions on Wednesday? No? Okay, so what we're going to look at is in sharpness recorded detail, because that's really what your magnification, your distortion is all about, is sharpness of recorded detail and giving us a better image with sharper image and doing the things that we need to do to make sure that we can see what we need to see, either because of the sharpness or we want an accurate representation of the anatomy that we're looking at. So size, shape, and without fuzziness, so sharpness recorded detail. So we're going to talk about the effects of SID, the effects of OID. Those two things together give us our magnification. We're going to talk about the effects of centering, which we tend to not really think about all that much. You put it in the light and you shoot it, right? So if it's in the light and you shoot it, then you're going to have a sharp image, but it's really not that simple. So we're going to talk about the effects of angulation, object shape, object size, image receptor resolution, and the effects of monitor resolution. So we're going to spend some time talking about these things. Even though the chapter doesn't go deeply into those, it's kind of an introduction into digital imaging and the challenges that we have with digital imaging and the things in the digital image that will control our resolution. Both our actual recorded detail and our display, which are really two totally different things. All right, so we're going to start with geometric factors, which are going to be your magnification, your distortion, your focal spot blur. So really where we're going to camp today is on magnification. We might touch on distortion. but we certainly will not get into focal spot blur until after spring break. So magnification is a type of distortion. It's just equal distortion all the way across the image or across the object. The entire object is distorted equally. All right, so that's what we call size distortion. Magnification, size distortion, equal distortion all the way across the image, all the way across that object. So we've looked at this over and over again over the last 2 semesters. If we have no magnification present, which is impossible, we always have magnification present. We'll talk about that in a minute. But if we have no magnification present, then we have really no loss of sharpness or recorded detail, right? So if we could take the anatomy and put it directly on the image receptor, and the image receptor had no depth to it at all, then we would have no distortion. It'd be like putting my hand directly on this and looking at the shadow. The shadow is going to appear very, very sharp, right? But the further I back away, and we're going to do this, the further I back away from my image receptor, which would be the screen here, but the further I back away from it, the larger this thing gets and the fuzzier it gets, right? So we get magnification, and with the magnification, we get a loss of sharpness or recorded detail. So we lose sharpness with increased magnification. So increase in SID, though, decrease in magnification. There it is. All right, I'm going to silence this. Let's do this. No, it doesn't matter. We'll do that one. All right. So, I'll hand you this. So, if I put this all the way up against the screen, again, I've got very minimal magnification, right? But if I increase my, now this is going to be analogous to our SID. I increase my SID, these tiles on the floor are 24 inches, so if I go to right here, that's, I would say, roughly 35 inches. All right, so I increased my OID 35 inches. So go ahead and pass that all the way back to 80. Watch what happens to the somebody hit the button and kind of started flashing. What happened to the size? It get a little dim. You might want to, telescope it and make it telescopes. I think you gotta extend it. There we go. So what happened to the overall size?
Got bigger.
Did
it get bigger?
Okay, pass it all the way back up. Y'all gotta try to stay on this though. Okay, so you see how fuzzy it is, right? And it appears wider in the edge. Okay, so try to stay on it and go back. Challenges. All right, you see? What happened? Did it get bigger or did it get smaller? It got smaller. Right, right. So as we increase OID, and it probably is not on that, so maybe we'll have to run back through it on the other screen. As we increase OID, what do we get? Magnification, right? But if we increase SID, then what happens? It compensates for it, right? So we lose some of that magnification as we increase SID. So think about the types of exams we shoot at 72 inches. Why do we shoot at 72 inches? OID, right. Lateral C-spine, always at 72 inches. I say always, if you can get 72 inches. If you're working a trauma situation, you might not be able to get 72 inches, but if you can, get out to 72 inches. Because of the increase in SID, we increase increase in OID, we increase our SID to compensate. And what happens, what you might have seen and what you might not have seen, is not only did the size of the shadow decrease with the increase in SID, but did you notice it got sharper again? Did you notice that? Or we need to do it again? And we'll torture y'all with it this time. Did you notice it? Yeah, it got much sharper. So you increase the SID, and sharpness is is reestablished. No, wrong one. Sharpness is reestablished and the magnification decreases, right? So increases in SID decrease, magnification increases, or magnification increases as OID increases. So what we've got working against us there is body habitus, body thickness or part thickness, body position, and also exam type, right? So I can, just off the top of my head, I can think of 3 things. 2 are in the textbook, always use 72 inches. And the other one was something, it's just a recommendation that I think I made. And it may be actually be in Merrill's this time. It used to not be, but that would be acromioclavicular joints. If you remember, we always do those upright with and without weights. And if you do it at 40 inches, because of the divergence of the central ray, you'll project them off of the image receptor in a lot of cases. But if you back up to 72 inches, you can get them, right? So body habitus, body thickness, body position, and also, exam type. So object shape also has a problem, or you have a problem with magnification with different types of shapes. And we've talked about this a little bit as well. Think all the way back to upper extremity. First part of last semester. We talked about wrist bones, right? What position do we shoot wrist bones in? Body position. Or position of the wrist, not the patient, but the wrist bones. What do? We do AP? Or is the hand prone or supinated?
Prone.
It's prone, right? So we shoot a PA. Shoot in PA, right? But I did mention that there's a better way to shoot them if we want to see those carpal interspaces, and that was AP, right? And the book makes that recommendation, and it's a registry question. You very well may see whenever you take your registry, is that the wrist bones are kind of conical in shape, right? And that's I say it's probably a registry question because it's in every registry review book that you'll see. It says that because of the conical shape of the wrist bones, it would be better to shoot them AP as opposed to PA. And what that means is conical just means cone-like, right? So they're skinnier on the anterior surface than what they are on the posterior surface, if only by a little bit. So how does your beam come out of your x-ray tube? What kind of beam do we use? A divergent beam, right? It diverges, so it comes from a very small area and it spreads out like that. So if, I'm gonna bring one of these up. If our x-ray beam diverges like so, these are gonna be exaggerated wrist bones, but if our x-ray beam diverges like that, and I take my wrist bone and I put it with a skinny part down like that, am I going to see some magnification of those wrist bones? The answer is yeah, because the fattest portion of the wrist bone is furthest away from your image receptor, right? So if you have the fattest portion furthest away from the image receptor, then your sharpness is going to come off of that periphery with an increase in OID, object image distance. You're going to have 2 things. One is it's going to get bigger. We call that magnification shape distortion, or size distortion rather. And with that, we're going to have loss of sharpness of recorded detail, right? So if though I take that bone and I flip it around until the fattest portion is at the bottom, right? Then what can you say about my magnification now? Is it going to be worse or is it going to be better? It's going to be better. Better in context of having less of it, right? So if we have less magnification, we're going to have more sharpness of recorded detail, right? So, so that'd be an example of wrist bones, but there are other anatomy as well that would be better if we shot PA. Spines, at least a portion of the spine. T-spine, we're ideally situated for T-spine, but L-spine is the other way around. Remember, again, back to last semester, we have curves in the spine. We have primary and secondary curves, right? C-spine, we've got a lordotic curve in the C-spine, we've got a kyphotic curve in the T-spine, a lordotic curve in the L-spine, and a kyphotic curve in the pelvic sections, right? So we have C-spine, T-spine, I should have done this from the back, L-spine, and then we've got pelvis, sacrum and coccyx. All right, so now our x-ray beam is over here. Since we've got our perspective, CT, LP, right? So since we've got our perspective there, let's say we're shooting a C-spine. All right, so with a C-spine, what we've got, our vertebra, again, is very exaggerated, but we've got our vertebra that look like that, right? And we've got 7 of them. So our interspaces, our disc spaces, are like so. You follow me? We've got vertebra, 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 and our disc spaces are like that. So how, though, is our central ray coming out? Our vertebra are oriented like that, and our central ray is coming out like so. Is it not? So is that ideal? The answer is no. It's exactly the opposite of how we would best see those disc spaces, right? They're like this. So in the T-spine, though, we're going exactly the opposite direction, so that we've got our spaces, and this guy's, he's missing a few T-spine vertebrae, but our central ray is here, and our x-ray beam would go right through those spaces on a T-spine. Is that ideal? Yes. Now our T-spine's going this way, our spaces are going this way, and our central ray's going the same direction, right? Wide open. But we're going back down to the L-spine, and what does that look like?
The C-spine.
The C-spine, exactly, the C-spine, so it's not ideal, right? So our central ray is, boom, does good there, but it hits every other one, right? So, we shoot an AP of the L-spine most of the time, but which way would best align with align the bones with the divergent central ray? Would it be AP or would it be PA? PA. Would be PA, right? Okay. So why don't we do L-spine's PA? OID. Okay, very good. That's great thinking. OID. If we flip the patient around, where is your L-spine? We don't say my front hurts, right? You say my back hurts because it's way back in the back. You shoot PA and you're going to have a natural increase in OID. It'll line up well, right? But you'd have a natural increase in OID. So is there another reason? Much more practical. You ever had a backache? Yeah. Climb on a hard table on your belly if you got a backache? Yeah, probably not. Probably not. So we shoot AP, but in context of the object shape and the object orientation to the X-ray beam, PA would be a better orientation. All right, so I will never get those right. There we go. All right, so magnification, we've got 2 ways to calculate magnification. So if you know the image size, then you can use image size over object size, but if you do not, then what you've got to go with are your distances. So magnification factor can be calculated as image size over object size. Your magnification factor is always going to be over 1, and I'll explain that here in a minute. But your number and your magnification factor is always going to be greater than 1. You're never going to have a magnification factor that's less than 1. So if you're setting up your formula right, so if you know what the image size is, you know what the object size is, first off, your image, because you're always going to have magnification present, your image size is always going to be larger than your object size. Okay? Image size is always going to be larger than your object size. And that's the image size at the image receptor. That's not necessarily the display size. We'll get to that here in a bit. But your actual recorded image size is always going to be larger than your object size. You can't get around it. So let's say you've got a question that says, okay, your image size is 4, your object size is 5. Is that possible? No, it's not possible. So, you know, you can work through the calculations, but essentially what you've got there is a question that's asking you for something that's impossible. That's a none of the above type thing. You know, what's your magnification size? If all of your choices are 1 point something, it's impossible. And we'll work through that here in a minute as well. So image size is always going to be larger than the object size, even if you don't see it on your image receptor. The recorded image size is always going to be larger than the object size. The other way is SID over SOD. And where you're going to make a mistake on this one is in your SOD. Your SOD is your source to object distance. So you have to calculate SOD before you can work this, right? So SOD is going to be source to object distance. And how you find SOD is subtracting the OID, object image receptor distance, from your SID. Okay, that's your step number 1. And that's the one step that you're going to have a tendency to overlook. What you're going to have a tendency to do is go SID over OID. Don't do that. You have to take OID from your SID to establish your SOD before you can work this out. Source to object distance. Now, object may not be, you know, the skin surface. It's whatever object you're trying to calculate that magnification for. Kidneys inside the patient. You know, the bones inside the patient, whatever, right? So what you're going to get in most cases with magnification factor, you know, you're going to get everything that you need to work the problem, but you might not get SOD. What you might get is OID, SID. You have to calculate your SOD to make this work. Okay, don't skip that step. So magnification is controlled with SID and OID. We just looked at that. What we want is as small an OID as possible. Can't get 0. We're always going to have some sort of OID present. We'll talk about that in a second. But also we want acceptable SID. So our established distances are 40 and 72 inches. And that's adequate. It really is. When I used to work a lot of ER, if I had the opportunity, I did some experimentation. Not anything that would, you know, negatively affect the patient, but I did some experimentation with different SIDs, thinking that if 72 inches was good on a lateral C-spine in the ER, then 10 feet would be better. Because the problem that you run into with lateral C-spines is this. They market this thing as unbreakable. I'm going to test that. Sooner or later, this thing's hitting the floor. But the problem that you run into with lateral C-spine is not just the magnification, but also because of the divergent central ray, you can project the lower portion of the C-spine into that downside shoulder, right? So what you need to see on a lateral C-spine is C7T1, right? So to kind of, I don't know, mitigate the divergence of the central ray, I started experimenting with 10-foot SID. so that the longer your SID, the less divergent your central array, right? So you back up your SID and collimate down, and more, the further back you go, you're using more of the center of the central array. Of course, it came with increased mass. It didn't really affect the patient dose, but had to use higher mass because of the inverse square law, right? So in theory, I should have been able to see C7T1 better in more patients. The effects were really minimal, right? So it's not that I wouldn't recommend it, it's just that it's not necessary. 72 inches is adequate. You're using enough of the center of the central array at 72 inches that extra 4 feet really doesn't do a whole lot for you. So all that way to say, we're looking at an acceptable SID, 72 inches is enough. And if we have an increase in OID, we can offset the effects of that magnification that comes with the increase in OID with the increase in SID. We took a look at that just a minute ago. And you can completely nullify that as long as your ratio remains the same. And what I mean by that is if you took a image with 1 inch SID or 1 inch OID, you increased your OID and 40 inch SID, let's say. So you have 1 inch increase in OID at 40 inches. If you increase your OID to 2 inches, that's a factor of, you went from 1 to 2, that's a factor of 2, right? And you used an 80 inch SID, then it would completely nullify the effects of the increase in OID. In other words, you double your OID, if you double your SID, image size remains exactly the same. Okay, so you completely nullified. So magnification is always present. Even if you're doing tabletop exams, you're going to have some degree of magnification because of the construction of your image receptors. The image receptor, the sensitive portion of the image receptor is covered by something, right? Even if it's tiny and very thin, there's still something there. Even if you're shooting upper extremities, very thin, right? If you're shooting upper extremities, though, the bone is what we're looking at, and that's inside of the tissue. So you're always going to have some magnification. Your image size is always going to be larger than your object size. Even if it's just minimal, even if it's only a 1% magnification, it's still going to be there. You still have magnification. So the soft tissue on tabletop images gives you an increase in OID because the soft tissue is generally not what you're looking for. You're looking for the bone, right? So it's going to give you an increase in OID, which is going to give you some magnification. And then if you're shooting in a bucky, be it a wall bucky or a table bucky, there's a distance, right? So even if it's only a couple of inches, there's a distance between the image receptor and the object. You got to go through the table. You got to go through the grid. You got to go through the gap in between the grid and the image receptor. There's an increase in OID. Even if it's minimal, it's still present. So that's going to give us some degree of magnification. Even if it's, I won't say irrelevant, but even if it's so minimal that it's imperceptible, it's present. Right? So I'm beating this to death because I want you to know the magnification factor is always going to be at least 1 point something. All right, so the image size doesn't always demonstrate magnification, but it's present because it can be very minimal. Actual image size is determined by the exam selected. The collimated field gives us appearance of magnification or loss of size, demagnification, so to speak, in the digital world. And what I mean by that is, again, if you shoot an x-ray of a hand and you don't collimate, then your computer has to put all that information together in formulation of your image, right? So it thinks that this hand, if you don't collimate or you don't collimate enough and you leave your collimated field open more than what you should, then it's got to, it thinks that your hand, even, you selected hand on the menu, it thinks your hand is as big as your collimated field. So in display, it's going to give you a smaller hand, appearance of the hand, than what would be represented by the actual anatomy. Does that kind of make sense? So collimation has always been important. If you remember again back to last semester, we talked about why we collimate and why collimation was implemented by Rollins. You remember what those purposes were, or the main purpose was? Dose. Reduced dose, right. So we're reduced dose, but there was a secondary benefit, and that was if we expose less tissue, we create less scatter radiation. If we create less scatter radiation, we create less fog. And less fog, we get a better image, right? So our visibility to recorded detail increases. So the dose portion of all that is still applicable. You expose the patient to less radiation. Even if you're shooting a hand, you're exposing the patient to less radiation, because if you center in the correct spot, and say that hand, again, you're gonna center to the third metacarpal phalangeal joint. And if you open your collimation to, a point way out here, then naturally the other end of the collimation is going to be somewhere else, right? And you're going to be exposing too much tissue. So it's still applicable. Collimation is still applicable. Increase collimation, cut the patient dose. Theoretically, is still applicable in your scatter radiation effects on the image, even though we walked through that in the last section. Scatter radiation will have less of an effect on the completed image than what it used to, right? Because the computer algorithm controls your contrast. But you shoot a finger, let's say, on an image receptor size that's 14 by 17, and the display of that finger is going to be about that big on your screen. Okay? So an unintended, or I guess unexpected, consequence of lack of collimation now becomes display size. You don't have a problem with magnification, you have a problem with minification on your image display. The recorded image remains the same, but what you're going to see on your screen is something very, very small. So twice a year we have what we call an advisory committee meeting with all the department heads for the hospitals where we do clinicals come to campus, and we feed them and we give them program update and ask for input. What are you seeing in clinicals? What are you seeing in students? What's going on that we need to address in the classroom? And we had radiologists come sometimes if we can get them here. And one year they came, and that was their topic, was that we're not seeing collimation. We just don't see collimation. It's screwing up the image that we see in our office. We're seeing hands that come out about that big. They're just not collimating. They're giving the illusion that they're collimating, because after you can post-process and you can make it look like to untrained eye that you collimated an image. Let's say you shot that finger and you said, I made all this exposure that I don't need. What can you do? Shutter, right? So people shuttering much more than collimating, and I understand you're not fooling anybody if you do that. Everybody knows what the shutter looks like versus collimation. And that doesn't do anything to the image size. The computer still thinks that you shot this massive hand, so you're still going to have this little bitty tiny image. It's just going to be well shuttered. Okay? So go all this way to say, when you're in charge of your own, image processing and sending those images to the radiologist, first off, make sure you collimate. Use collimation. It's your ethical responsibility to collimate and reduce exposure to the patient, right? But also, it's going to affect your image. And if you shutter, you're just, number one, you're not fooling anybody. And number two is that anything that you expose the patient to, you are ethically responsible for sending that information to the radiologist to read it. So let's say you got an order for a finger, you shot a whole hand. should you shutter it down to a finger? Answer is no. Patient paid in dose for that entire hand, right? But what if I get in trouble? Well, you should have shot a finger, right? You should have done your job. You should have collimated down to the finger. You should have shot a finger, right? So, is there a time to shutter? And the answer is yeah, but don't shutter off your collimation. Otherwise, they're going to think you just shuttered, okay? So, what I mean by that is, if you collimate it tightly, then show the edges of the collimation in your shuttering. Does that kind of make sense? Show just the edge of the collimation in the shuttering, and don't shutter off your collimation. Don't make it look like something that it wasn't. So, magnification factor, I can get off my soapbox now, is always going to be 1 point something. Okay, so let's go back to our formulas for magnification factor, and we'll end here. Okay, so image size over object size. Let me get rid of this. I say get rid of this. Okay, I don't want to get rid of either one of them. This thing's mad at me now. All right, we'll do this. Just turn it off. It won't even turn off. All right, do it. So image size over object size. Let's say you've got a problem that says that you made a image of a hand. Since we're on hands, let's say you made an image of a hand, and the image size the size of the hand was, I don't know, 5.1 inches. We're going to go with inches. All right. The image size was 5.1 inches. The object size was 5 inches. Okay. So how do you calculate that? Image size over object size. So 5.1 over 5 is going to be, Oh, my calculator's up there. Yeah, thank you.
It says 1.02.
Over object size. 1.02.
Where did you come from?
0.1 is
Yeah,
10.
0.1. So, you got 5 divided into 5.1. So you've got a larger image than, larger image than object. So your magnification is going to be minimal. That 0.02 is your overall magnification, but it's still going to be larger than 1. Okay. So if our image size and our object size were the same, let's say 5 over 5, then let's say we cut all the soft tissue off the hand, cut the bone, this obviously a cadaver, cut it down to paper thin bone size and put it directly on the image receptor, we would have an image size that's identical to our object size. That'd be 5 over 5, right? So in that case, our magnification factor would be 1, right? So when we're talking about percentages, let's see, type in, somebody with the phone up, type in 100 and then hit the percentage sign. 1. Okay. What that represents is 100% of the object size. Nothing else. It's 100% of the object size. So whatever comes after that decimal, in this case was 0.02, because we have very minimal magnification, then what that represents is the percentage of magnification. Okay? So your overall magnification, your image size is 102% of your object size. Okay? It's 2% larger than your object size, is what that is. Okay? So again, if you've got a question on the test that those two things are exactly the opposite, and this is image size and this is object size, then what do you have? It's like dividing by 0, right? You divide by 0 and what happens to your calculator? You don't get anything, right? Does that make any sense? So, you know, you're gonna have to look for something smaller than 1, which is impossible. Object size is always going to be smaller than image size. Magnification factor is always going to be greater than 0.01. So if you work something out and you come, I'm sorry, 0.01. 1 is 1%. 100%, your image size is always going to be at least 100% of your object size. Really, it's always going to be greater than that. So it's going to be 1.0 something, always. If you work it out and you come up with something less than 1, you messed up. Always greater than 1. Okay, any questions?